Thanks very much. Thanks a lot for inviting me. So the short answer to that question is, I'm afraid, very little indeed. Just to remind you what we're talking about the syndrome of dementia, which comprises a triad really of progressive cognitive impairment or decline, severe enough to impair activities of daily living and often associated with behavioral and psychological symptoms. There are multiple causes of dementia, as you probably all know, of which the largest single group is thought to be the primary neurodegenerative diseases. Other causes include secondary systemic illnesses such as vitamin B12 deficiency, hypothyroidism, and the consequences of alcohol abuse on the brain. Especially important in our context, as Sebastian has already spoken about, are systemic infections which affect the nervous system, particularly HIV. So if one looks at the primary neurodegenerative diseases causing dementia, Alzheimer's disease and vascular dementia or cerebrovascular disease are thought to account for 80% of all cases of dementia in Western Europe and North American studies, with Alzheimer's disease being by far the commonest. We don't know what that ratio is in our area, in sub-Saharan Africa. Suggestions are that vascular disease may be more prevalent, possibly due to untreated hypertension or poorly controlled vascular risk factors in midlife. But in any case, the current thinking is that multiple pathologies often act synergistically in the pathogenesis of the dementia syndrome. Even the entities of Alzheimer's disease, in which there is an abnormal accumulation of the proteins beta amyloid and phosphorylated tau in the brain, and the entity of vascular dementia, which affects the blood supply to the brain, are thought to frequently overlap or coexist in the same patient. So if one looks at the risk factors for dementia in general and of Alzheimer's disease in particular, there are the non-modifiable factors which we can do nothing about, like getting old, the ApoE genotype, and rare familial inherited autosomal dominant forms of Alzheimer's disease. The potentially modifiable factors include midlife hypertension, other vascular risk factors such as smoking, uncontrolled diabetes, hypercholesterolemia, and physical inactivity, diet, depression, chronic stress, loneliness, low education, and poor cognitive reserve. The converse of these factors would potentially also be protective against the development of Alzheimer's disease. This is a graph from Germany, but it could be from any industrialized country, illustrating the well-established fact that Alzheimer's disease is in fact age-associated and that the prevalence increases exponentially with age, rising up to 50% in people over the age of 90 in this particular study. And this slide's been shown often before. Just to remind you once again, the sub-Saharan African population is aging. If you look at the number of people over the age of 60 years in sub-Saharan Africa and South Africa, it will at least double over the next 30 years, due both to an increase in the population size as well as an increase in life expectancy. So this graph shows the projection for the number of people likely to be suffering from dementia in the next 20 or 30 years. And as you can see, the majority of cases will in fact be in the developing rather than in the industrialized world. So the questions we'd obviously like to know is what is the prevalence of dementia in sub-Saharan Africa? Are there rural versus urban differences? Are there regional variations in the prevalence? What are the subtypes? Is vascular disease really more common than Alzheimer's disease? And of course, as Sebastian has already alluded to, what are the appropriate cognitive tests for the diagnosis given the socioeconomic, linguistic, cultural and educational diversity within sub-Saharan African populations? What are the risk factors? And are there any biomarkers that may be useful as well? And this is an obvious slide in the way why I study it. Well, obviously we want to define the magnitude of the problem and hence determine what resources are needed to support and care for affected persons, their families and carers, to inform policymakers, to identify causes and risk factors, especially the modifiable ones, and the latter may in fact even be peculiar to a particular area or population. So I'm not going to comprehensively review all the previous studies, which have mostly been small, actually, of dementia prevalences in sub-Saharan Africa. But here's an excellent review, which is only a little out of date, published in the Bulletin of the World Health Organization a few years ago. Essentially, what these studies have indicated up to now is that there are markedly varied prevalence rates reported, anything from 0 to 10% in people over the age of 60 or 65. Professor Adeshole Oguni from Nigeria has done lots of work, has been a pioneer in this field in the Ibadan region of Nigeria. What most of these studies have shown actually is that older age and female sex were associated with a higher prevalence of dementia, and that the overall prevalence rates were lower compared with European and North American studies. Not surprisingly, perhaps, but because there are fewer people over the age of 80 in these countries. So just to finish off, I'll tell you briefly about a study that we conducted ourselves in a poor rural region of South Africa, a prevalent study of dementia, cross-sectional study, which was performed in collaboration with 2 NGO groups. We screened people over the age of 60 years in 3 well-defined catchment areas in a poor rural area of the Eastern Cape, using the brief community screening instrument for dementia, or CSID, which was developed by the 1066 group, which has known sensitivities and specificities, at least derived from other low to middle income countries. The screening tools were translated into the local language, isiXhosa, retranslated, back translated and piloted before the study. We screened about 1,400 people, mean age 71. Most of them were women, and most had only limited basic primary school education. Whether we used the published sensitivity and specificity values for the CSID or cut-off scores, we got similar estimated dementia prevalence rates, which was that of 11% in people over the age of 65 and 8% in people over the age of 60. And of course, we showed the classical age association of dementia prevalence as well. So the prevalence rates we obtained were higher than those of the 2015 World Alzheimer Report estimate for South Africa, which is only 4%, and therefore by projection, by extrapolation, if we can, the estimated number of people over the age of 60 living with dementia in South Africa would be almost double what the World Alzheimer's Report suggested. There are some limitations to the study. I can't go through all of these now, but the main problem was that there was no validation of the screening positives or negatives by medical specialists using other clinical diagnostic criteria. Therefore, dementia subtypes could not be identified either. And then just lastly, 2 quick slides on HIV-associated neurocognitive impairment. This was included in the study. We looked at the prevalence of HIV by age group in this population, and it was found to be about 8% in people between the ages of 60 and 64, but tended to decline, being only about 2 to 3% in people aged over 75. We also compared the dementia status of HIV positive versus HIV negative participants in the study across the age groups and also within the age groups. The HIV positive individuals are indicated by the filled bars and the negative by the open bars. And you can see in both cases the increase in dementia prevalence with age, as we saw before. But interestingly, if you took each age group, the prevalence of dementia was always higher in the HIV positive than the HIV negative groups. So what we conclude from that is HIV infection certainly exists in a rural older South African population. It contributes to cognitive impairment, and it may do so either by accelerating neurodegeneration or accentuating the aging process. So that's all I can say in a few minutes. Thank you very much, and I welcome any correspondence by email.
Thank you very much, Marc. I hope that that people will email you questions. We've run out of time in your slot, but I'm sure there are many questions that people will have, and I do encourage them to correspond with you. Thank you. Thanks again, Marc.